Good day, everybody. My name is Kulvinder Bajwa, and I'm from UT Health in Houston. We'll be talking about revisional bariatric surgery and what robotics can add. I have no disclosures. The IFSO 2019 report, which mainly concentrated on surgeries between 2015 and 2018, showed that almost 38% were revisional surgeries. Well, what are the revisional issues and what makes them special? Essentially, you can see that almost 18% of revisional surgery have complications which are higher, almost 2 times the primary surgeries. The mortality is definitely higher as their risk factors are not managed well at that point. The weight loss is less than their primary surgery, and their weight loss effect is less as well. And definitely, there's longer operative times. So what are the general advantages of robotic surgery? And this is the mainstay of the intuitive Da Vinci Xi platform. What you're going to see is that the camera is located in the natural center between two working instruments. This can maintain your dissection space right in the center. Longer instruments to reach the posterior mediastinum to the ileocecal valve with a single docking maneuver has been an evolution of this technology. The robot does compensate for torque in thick abdominal walls without having to feel it in your wrists. This can definitely help with visualization in higher BMI patients without having the loss of insufflation or having two insufflators to maintain your pressure. The views can be changed easily on the console without having to flip or adjust the cameras too many times. The ergonomics for having a seated position and floating wrists can have a good advantage when you have longer operating times. Suturing has by far the main advantage here, where you can have wristed instruments much more analogous with our natural motions for any kind of material and any kind of needles. And the laparoscopic camera is somewhat limited, where the robot camera can give you a depth with two cameras mounted in the tip of the camera. Checking the perfusion with ICG technology is analogous with both laparoscopic and robotic platforms, but this can be changed very quickly without having to change cameras. The surgeon does have full control over the camera, retraction, stapling, energy, and dissection as well. There are more advantages. Trocar placement and docking can be efficient with an experienced team, and oftentimes most places have this, so there's little time wasted in docking the robot. The gastric dissection is key when we do revisional bariatric surgery. And this revisional surgery can maintain perfusion and have very good, precise dissection planes. We can staple now with a robotic platform, which can be done either independently through an assist port or simply just from the robot itself. The anastomosis is the next thing, where we can concentrate on either a hand-sewn or stapled platform, and of course the closure of the enterotomies. We'll go through a little bit case-by-case basis in later slides. The main thing is for return for related or unrelated surgery. When you use the robotic platform, we find that there are less adhesions, less hernias, as we're usually using 8mm ports. And when combined with other specialties such as gynecology or urology or even colorectal surgery, it can be great advantages to maintaining the same ports. For us who are teaching robotic surgery, 2 consoles has a distinct advantage over laparoscopy, as you can hand over all the controls or just one control without having to switch positions time and time again. What are the index operations that need revisional surgeries? As you can see, the gastric bypass, the vertical banded gastroplasty, which has had several issues of obstruction, the melena band, which often come in obstructed prior to any great symptoms, as well as weight gain, the laparoscopic adjustable gastric band, which has many patients out there, and they are still being revised slowly as they become either problematic or are seeking another surgery for their inadequate weight loss. Sleeve gastrectomy, even though it's only been around for approximately less than 10 years, the sheer numbers of people getting sleeve gastrectomies and then being lost to follow-up or having inadequate weight loss are coming in for some revisional bariatric surgery. Then to a very small degree, the people who have had a jejunal bypass of the past, they're also coming in seeking some revisional surgery. Now we have endoscopic gastric procedures who initially had started and now are seeking for a more robust weight loss procedure. And then we have people who've undergone previous anti-reflux procedures and have either recurred or now are seeking bariatric surgery. And then, of course, previous open or laparoscopic surgeries now seeking bariatric surgery. Let's see when we approach the adjustable gastric band, which is one of the main revisional procedures that we encounter these days. The robotic dissection for both the sleeve or the bypass are key when you're taking off the band and then disconnecting the capsule, which is circumferential dislocation, as well as the plication. To maintain an even sleeve without a dog ear for both the bypass staple line as well as the sleeve is a great advantage in the retrogastric location, as well as dissecting out the left crus from that very scarred-in location. Some of us prefer the pars flaccida technique, but some prefer the perigastric dissection. And the perigastric dissection is very much possible using the vessel sealer as well as maintaining the blood supply, especially if you have more scar and fibrosis. When people have had a previous hiatal hernia repair along with the gastric band, this can be a very, very tough dissection. And this can be even tougher when you have an erosion which has been asymptomatic. The robot is key with both the scissors as well as the visualization in this retrogastric location to maintain a small pouch or an even sleeve, which is even between the antrum all the way up to the left crus. The robotic surgery platform can be used for a concurrent band removal or an interval revision. And of course, conversion to a DS, the Da Vinci platform can be used. Now to kick it up a notch, fixed gastric band, usually done through open surgery with an upper abdominal incision, robotic dissection for a posterior capsule and the angle of His. These are all common concepts, but having a fixed camera and steady retraction to maintain that tension and view is a greater advantage with the robot platform. Since most of these will be converted to a gastric bypass, the posterior dissection for the stapling of this small pouch towards the left crus can be very difficult, but using the vessel sealer as well as scissors and cautery and maintaining this dissection space is key, and even more so when we're repairing a concomitant hiatal hernia or suturing. The intense fibrosis from different materials of these fixed gastric bands can be tricky, and we can use these for concurrent band removal or coming back for a revisional procedure. For the jejunal bypass, the robot dissection for a resection and anastomosis of this bypass segment or interposition segment is going to be difficult, as these involve several dissections as well as anastomoses. These are converted to a gastric bypass, or you can convert these to a DS. The robotic stapler platform, which is much more evolved as a stable platform, as well as the common enterotomy and the GJ can be hand sewn, which have been done for quite some time now. Again, a concomitant hiatal hernia and suturing and multi-quadrant surgery using the Da Vinci Xi platform for a DS. So what are the advantages of revising a sleeve gastrectomy? Two ways to go about this. Some people do revise a sleeve to a sleeve if they've had an inadequate sleeve, and sometimes these inadequate surgeries can have no adhesions or if somebody has clipped the entire staple line, it can have very, very bad fibrosis and adhesions. This can be really the advantage. The more dissection you need, the more the robot can be your friend. From conversion to a bypass, again, surgeon preference, but perigastric dissection to maintain most of the blood supply with the vessel sealer is a good tool. The robotic surgeons have been doing hand-sewn GJs, minimizing two linear staple lines, which can compromise some of the perfusion when they're too close together. Hiatal hernia is a common theme, whether it had been done before or you're planning to do one now, but wristed instrumentation as well as hiatal dissection with most of these instruments is much simpler. Multi-quadrant surgery for the classic DS or even the single anastomosis DS can also be a distinct advantage. Let's tackle the bypass as it's been around for quite some time, and these folks come in with weight gain or inadequate weight loss. Sometimes they just need a revision from their bypass to another bypass for a poorly done bypass or having issues. Again, doing a perigastric dissection, if you're going to go up on the gastric pouch for a large gastric pouch, can be good on the robotic platform. Hand-sewn gastrojejunostomy, minimizing two linear staple lines of a very small pouch. Repairing a hiatal hernia if they're experiencing more reflux. And then this can be also used in root limb lengthening with or without a pouch revision to revise the gastrojejunostomy for a chronic marginal ulcer, as well as a large gastric pouch with or without a GG fistula, in a large gastric outlet, which is just a pouch revision, or if they've been previously had some sort of intervention endoscopically. Now with evolution in endoscopic and endoluminal gastric procedures, whether they're done for reflux or for weight loss, these usually are converted to a sleeve gastrectomy or a bypass as being the majority of the procedures done around the world. The keys in handling and dissection of the stomach, as the pliability of the stomach can sometimes be a little bit stiffer, and having two wristed instruments to try to flatten out the stomach while doing the sleeve gastrectomy or creating the gastric pouch are key in these dissection techniques on the robotic platform. As we've mentioned before, posterior gastric adhesions can develop similar to acute pancreatitis, and these can be handled fairly simply on the robotic platform. There's enormous value repairing. Now we're seeing folks who've had a previous anti-reflux procedure or endoluminal procedure coming in for weight loss surgery. If there truly are terrible reflux patients, I think they should be converted to a gastric bypass, but some of them have mild reflux symptomatology and just want the weight loss, and these could be offered a sleeve gastrectomy. I think the dissection around this space can be extremely easier with the retraction on the robotic platform, but to maintain an even sleeve and flattening out that stomach and minimizing their leaks on the robotic platform is key with the wristed instruments. Even for the creation of the small pouch and the posterior gastric dissection, the robotic platform is a great advantage. So now that we've revised all the bariatric surgery, what is the future? Endoluminal robots are being developed to keep the platform stable, as well as having more wristed instruments and capabilities endoluminally. On your laparoscopic platform, handheld wristed extensions, creating wristed instruments as well as dissection space. Single-armed robotic platforms, so they are interchangeable, are being developed, as well as single-site platform, as well as multi-arm platform, other than intuitive. Reduced port surgery, as well as more capabilities in each of these platforms is being evolved. And are we ever going to go to autonomous surgery? Thanks for listening. And as goes with all revisional procedures, sometimes there's more questions than answers.